Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We did not have this show scheduled, but I thought that the issue of coronavirus, which you're all hearing a lot about through the news media and print, and we've had a lot of calls here to the university questioning what's going on. What should I do? So I'm bringing you the experts. There they are. They're sitting in front of me. To my left here is Dr. Bindu Maya. She's a professor of microbiology. You might remember she appeared with us during a crisis we had a couple of years ago on Zika, and she was a big spokesperson for the community at large. And now she's here to talk about this, what I believe to be a potential insidious problem. Welcome.
Thank you.
And in front of us is a dear, dear, wonderful person. I guess I'm not supposed to say that. I'll just say doctor. How about that? But you are a dear, dear, wonderful person.
Thank you.
Dr. Naushira Pandya, who is an extremely well-known and honored geriatrician. She's the professor and chair of the Department of Geriatrics here at Nova Southeastern University, Kiran C. Patel College of Osteopathic Medicine, and she's the project director of South Florida's GWEP, which you'll tell us what that is. Dr. Pandya, welcome.
Thank you so much. Very honored to be here. The GWEP, as we call it, is a federal grant for geriatrics workforce enhancement program. So we're involved in training residents, community members, and improving clinical care of the elderly.
Let me get to the reason why we're really doing this show, because the people out here are starting to send in a lot of questions. So tell us what this whole coronavirus issue is as we know it, because we're getting what I believe to be very spotty information and metrics coming to us. And our CDC is struggling to get information from the Far East, particularly China. You want to talk about it?
Yes, so this has been a virus that originated in China, and reports started coming up, I believe, end of December, right, and of a respiratory infection. But that has spread to many, many people, and also is related to deaths, which are still increasing in numbers. And scientists tested specimens very quickly to see what the originating cause was, and they found it wasn't a common cold virus, which also coronavirus is. Dr. Mayi will explain in much more detail, but this was a novel coronavirus that had not been encountered before.
Dr. Bindu, you're the expert, so tell us a bit about it.
Coronaviruses aren't new to us. If you look at the family of coronaviruses that are now, including the new one, about 7 of them, 4 of them cause just a cold. So we have a cold. There are other viruses that cause cold-like symptoms, and most coronaviruses just do that for us or to us. And then there was the SARS coronavirus in 2002, 2003 that infected just over 8,000 people and killed about 774 people, so about 9% mortality. But when you look at the elderly, it was more than 50%. And why are we looking at SARS when there's a new coronavirus is it tells us what to do. We learned a lot from handling SARS, and we're trying to implement those lessons here with the new virus. After SARS, in 2012, there was MERS, the Middle East coronavirus, which causes also atypical pneumonia like SARS. So the new coronavirus, like SARS and MERS coronaviruses, also causes pneumonia. But it's acting a little bit differently than SARS in the fact that it is showing asymptomatic transmission, or we think that it is showing a fair number of asymptomatic transmission. That said, it is a little too early to tell how it's going to pan out, what the mortality rate is going to be, how the spread is going to occur, whether it's just coughing or can it be inanimate objects that someone has coughed or sneezed on and is now contagious. So only, I believe, in the next few months, we will know a lot more about how the virus is spreading in the community.
I'm going to ask you, Dr. Pandya, has there been any indication, for example, that people who you recommend to your patients to take, in quotes, the pneumonia shot?
So that's a really good question. So coronavirus, of course, is not in the bacteria family.
Right.
And the pneumococcal vaccines, as we know them now, enhance your immunity to the bacterium, which is pneumococcus. But I think people who are vaccinated may have less chance of a secondary pneumonia. So the virus can affect the respiratory tract and cause, widespread inflammation, shortness of breath. And what I'm learning is looking at the clinical problems of the infected persons who've actually had extensive disease, that one of the major complications is pneumonia. And the pneumonia could be due to the coronavirus itself, but when you're compromised and your lungs are damaged, you can get secondary bacterial infection. So I'm theorizing that people who've had pneumococcal vaccine may have less chance of a secondary infection. But having said that, if you get to the stage of developing pneumonia, it is a pretty serious disease. And people who've developed pneumonia from this, so looking at the deaths in patients affected by coronavirus, they've developed severe respiratory distress syndrome, where they require a huge amount of oxygen by either ventilator or even external perfusion of blood through membrane to increase your oxygen levels. And they also suffer from organ failure, heart attack, compromising the cardiovascular system, heart failure, kidney failure, and even this whole sepsis-like syndrome where all the organs fail. So, vaccines would not protect from this extent of disease progression.
Well, I'm sitting here with a lot of non-knowledge relative to this particular situation, although I have knowledge, but I'm querying both of you because it seems, at least from the communications we're getting through media, that it's it's an oversimplistic feeling about malaise. I got a little cold or whatever, and then all of a sudden, at least what's being reported, there are deaths. Do we have a problem, Dr. Bindu?
I feel potentially yes. There definitely is a problem in China, and I think what we can do in the absence of all the knowledge that we will have a few months from now, the best we can do is take a preventive approach. So I feel what the CDC is doing, what the Department of Health and Human Services is doing is great. In addition, I think the rest of us can do just basic prevention, because I want to remind our audience that we are still in the midst of a flu season. And so far, at least 10,000 people just here in the United States have died of the flu. And of those, 68 of them are children, who is just heartbreaking to me when I read about that. So how do we prevent the flu if we are not getting vaccinated? The vaccine can give you protection against the flu up to a certain extent, but in addition, we need to do basic infection prevention. Be conscientious of where our hands are before we touch our face. Let us all of us have good cough and sneeze etiquette. Let us not do an open mouth cough or an open mouth sneeze, because that's how these respiratory infections can be spread so easily. These droplets land on someone's face, or they land on a surface, someone comes along, touches that, rubs their eyes, touches their nose, or puts something in their mouth, so they can self-inoculate. So if all of us had good cough etiquette, sneeze etiquette, and good hand hygiene, it will help prevent a lot of infections, not just the new coronavirus, but also the flu virus, also the common cold virus, so many other illnesses.
You bring me back to, I remember, I guess it was about almost 8-9 years ago when we had this really almost insidious flu, I guess you could say, exposure in our country. Mm-hmm. And everybody started to talk about, all the hand sanitizers. And in fact, even here throughout the university, we put up all these hand sanitizers around on each floor near the bathrooms and then near the elevators, et cetera, et cetera. You talk about cough and sneeze etiquette. Coughing into the I guess you can say the elements of the hand and the shoulder or the elbow. People say, well, that's sort of silly, but it isn't silly. It's an oversimplistic way of preventing other people from being exposed to what you might, you might be capable of dealing with it, but there are a lot of people that are out there that are immunosuppressed, particularly the elderly population. Isn't that true?
Yes, very true. And I think to just build from Dr. Mayi's points, you really have to, if you're sick, stay at home so that you're not likely to infect other people. And that's particularly true for healthcare workers. Now, of course, that creates problems and shortages, but you're really protecting yourself and other people. And the other people who are likely to get sick are the elderly, children, as you mentioned, people who have chronic conditions, especially chronic lung disease like emphysema, chronic bronchitis, heart failure, diabetes, if you have pre-existing kidney disease or liver failure, and especially if you're on chemotherapy or a cancer patient, and pregnant women. So your immunity is a little different. It's more compromised. So those are the people we want to, protect. And obviously, if those people have respiratory symptoms, of course, they could be a common cold or another virus, but we want to then be sure that we know their travel history and their exposure history.
Am I being oversimplistic, or is that's what happens?
No, I
Yes.
think that is what happens.
That is exactly-
Surfaces
Yes.
Go
in
ahead.
proximity to people who are sick.
Right. So the best thing to do in that case, because I like thinking of solutions. So it's one thing to say, yes, stay at home, which is great. I think people need to know they should do that. That's the ideal. But if that doesn't happen, the least they can do is take medications to suppress their symptoms. So if they're not coughing, it's the cough droplets that is getting it to someone else. But if they can minimize their coughing or sneezing, then they cannot completely eliminate the chance of infecting someone else, but they can minimize the opportunity for these viruses to get onto a cough droplet laced with saliva and mucus viruses and reach someone else. So if they can take medications to suppress their symptoms, or if they can wear a mask, perhaps, that doesn't interfere with their breathing, but it would eliminate how much they're putting out there. Right, Dr. Pandya?
Mm-hmm. Yes, in that case, it's a regular surgical mask.
We're sitting here at the epicenter of what I would call cruise travel. It's a major economic feature of South Florida, particularly Miami and the whole coastal area, but particularly Miami, Port Everglades, here in Broward County. And I say to myself, we were speaking before the show, you get in like in a 3-4 day cruise, something happens where you have some kind of an infective issue which causes stomach distress, diarrhea, things of that nature, which you read about it all the time.
Yeah,
but
it
then
becomes widespread.
Right, but it's a closed community, and it's really whether the ship is 4,000 or 6,000 or 7,000 people, it's a closed community. And I'm just wondering what kind of precautions are taken, because I know the airlines have made I guess it's a very positive, I believe it's a very positive move to not allow, people coming from the Far East, dominantly China, to fly into our receiving cities.
Or if they've flown through China.
Or if they've flown through China. I mean, what's your thoughts on that?
Yeah, it seems very extreme, and I know that it's causing a lot of, distress worldwide, but I think containment and is really important right now in identifying cases earlier. I mean, the cases we have in the U.S. are going up steadily day by day. I believe we have 11 now. Perhaps we would have more if we did not do this. And the worrying thing is, though, that there's asymptomatic transmission. So even people who are screened at the airport who may not have respiratory symptoms or have a fever could have the virus. And they are not symptomatic thus far, but they can transmit to other people. So that's still a worrying thing. I don't think there's 100% way of containing asymptomatic people.
Right.
Dr. Bindu?
What do you think?
I agree. And closing off borders is a start, but it's not fail-proof. It's not foolproof. So we already have individuals in the country who have been abroad, and we have returning travelers who have been to China, and they're U.S. citizens, so they're not denied entry, which they shouldn't be. But there certainly is the potential for spread. But I think what we're doing is, although extreme, and has ripples, is the right thing at this time. I think it's better to be known for having an exaggerated response and having stopped something from becoming an issue here than to do less and then rue the fact that you had the opportunity to do all these things and you didn't.
You know, I'm sort of hearkening back, and I know that it doesn't necessarily correlate, but I think of the response effort when we had the Ebola crisis. When you think of it, I mean, there was an incredible, capable response by our government and the various health agencies that we have in this country.
Right.
Do you see some of that being again energized, and has that set a pattern for us being able to control this? Because I understand, according to what I just heard on public radio, that there's well over a couple 100,000 people maybe that have been very clearly found to have the virus, so it's up to 400,000 people in China. That at least one of the reporters said. I don't know how accurate it is, but you know, that's a lot of folks.
Right. That number sounds a bit high. I know the latest I heard was over 17,000, but in any event, we don't know how fast this is spreading.
I know where the numbers are coming from. So if it's lab confirmed, it's about
17,000.
17,000, but they've also done some mathematical modeling studies that take into account the population size, that take into account the travelers from Wuhan to other parts of China, from China to other parts of the world. And based on those modeling studies, they call it nowcasting. So instead of forecasting, it's forecasting now. So it's called nowcasting. Those studies show that it's far more than 17,000 that have been exposed and possibly infected. So that's where the discrepancy in numbers are coming from.
That particular city in China is sort of like the old Detroit of America. You know, it's a major industrial city where they have factories where more than 150,000 people are working in various shifts. And so they're using similar materials, you know, and you know, you're hitting the same computer keys, things of that nature. Yeah. And I would assume that that's the transmission point. Is that correct?
Yes, so eventually, yes, with respiratory viruses, you can certainly, surfaces can be a mode of spread. But we think initially it came to us from bats, and right. Maybe there was an intermediate animal that has yet to be identified, yeah. Which is important for us to identify so we can avoid that point of contact in the future. But after that initial spread, and because these are viruses, and viruses by their nature mutate, that means they can adapt themselves to what's happening in our body. So after that initial point of contact, maybe there was a mutation that now allowed human-to-human spread, which is exactly what happened in the case of SARS, and which is what we're seeing now, human-to-human spread without that intermediate animal between the bat and the human. So bats are a reservoir for many different viruses, and coronaviruses are just one of them. I think one of the things we have seen, we saw it with SARS, we've seen it with Ebola, now we see it with the new coronavirus, is how are we behaving around wild animals, for instance. They're being used as food. So in Ebola, in the case of Ebola, there have been epidemics where it's been due to exposure to bushmeat, where the animals that were being slaughtered and used for food were giving us the virus, were giving humans the virus. And then, of course, it's so highly contagious from human to human. And the same thing happened in the case of SARS. There's a cat-like mammal called the masked palm civet, which is used as a delicacy in southern China. So in these live animal markets, from the horseshoe bat, where these viruses are found in the wild, they don't make the bat sick. From the horseshoe bat to the masked palm civet, only in these live animal markets the transfer took place, and then from masked palm civets to the humans who purchased them and slaughtered them and ate them. And then it was just a matter of time before it became human to human. So we think the same thing has happened with the new virus, but we're not entirely sure how.
Dr. Pandya, with the multiplicity of geriatric patients that are seen by you and the people who work in your practice, because we're down to the last 4 minutes of this show, and I just want because I don't want these people have anxiety over this issue.
Of course.
So I want to mitigate their anxiety. So give us the list. What should we do? What do you suggest?
So I think really follow the education campaign and the knowledge campaign that the CDC has mounted. And that's good advice. So common colds are common. Influenza is still, we're in the influenza season. So most people will have respiratory symptoms. That will not be this novel coronavirus. Of course, the people who are at risk are people who have traveled to China or through China who have come in contact with a confirmed case. So those are the people who are really at risk. So I would say if you have symptoms that you're not able to manage at home, let's say your fever is out of control or you're coughing and it's interfering with your activities, you're getting short of breath, seek immediate medical attention. And so practitioners then need to be aware that if they have patients with respiratory symptoms, they go through the simple questionnaire that the CDC has put out, just looking at travel history first to see what their risk of exposure is, and then managing, deciding whether they need to be tested specifically for coronavirus or just manage them symptomatically if they have no risk factors, and then to decide, are they better managed at home or do they need to be hospitalized? And that you would do anyway with any adult who is sick. That is the decision making we go through. And I think obviously keep in close contact with the elderly who are sick, who have respiratory problems. A regular phone call would help. And if they're not doing well, certainly they need to be seen again in the clinic. And if by phone they sound like they're really getting sick and having trouble, then they need to be hospitalized.
Not to make it oversimplistic, but I guess it is oversimplistic. A lot of people will call and I can't get an appointment to see my doctor for 2-3 days. That's not good. You need to go to a walk-in clinic, or you have to go. We have a immediate clinic right here. I'm not pushing over Southeastern University, but the ZIF clinic has a walk-in clinic.
Right.
And I'm sure. I know that all this controversy about vaccines and whatever, but I'm sure that you recommend that people get their flu vaccine and they get they get their pneumonia vaccine. At least once every 5 years. Is that correct?
It is correct. A flu vaccine annually, and certainly pneumonia vaccine after the age of 65. And now we have a course of 2, and certain individuals should get it earlier on. But I think we just have to practice good medicine and be aware of the people who are more vulnerable, the extremes of age, people who have diabetes, people who have heart failure, those who tend to go in and out of the hospital. We need to be extra careful when they develop respiratory symptoms. And that's true, I think, especially in this flu season time.
Call your doctor, Call your doctor. Communicate with your doctor. If you don't give them the information, you're harming yourself. Dr. Bindu?
Yes, I agree.
You agree?
Yeah.
Well, I thank you both for being here. Like I said, the purpose of having this program, and we're here on a special time. We usually don't film on a Monday, but they won't know whether it's Monday or Wednesday. But the bottom line is that I've had so many calls, and I think I think it's good that the media is making people aware of it, but I'm trying to mitigate the fear. That's why I had this group, both of you who are experts. And I think it's important for the people to recognize that there are people of knowledge, tremendous knowledge, like Dr. Bindu Maya. We all know what a incredible human being she is with her knowledge. And with you, Dr. Naushira Pandya, I know how you care. I know the value of your ethic, your wish to care, particularly in the geriatric field. So I wanted both of you here, and I appreciate you both being here. At a snap minute, we got you, and because I think it's important to try to mitigate some of the very extreme anxiety that we're starting to hear through the questions that come to us through the email address and the telephone number, which is right here. You don't see it, but it's right here right now. So thank you very much for being here.
You're welcome.
Yeah, you're very welcome.
And anything that we could do, we'll do for you. I can't make Dr. Bindu Maya any smarter than she is, because she is brilliant, and I certainly can't give any more conditions of caring and efficacy and kindness that are built into your world of practice. But thank you both for being here.
Thank you.
Folks, I hope we gave you some topical information. This program is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.